Last week you weren't here and we talked about hypertensive emergencies. So how long are you going to be here for?
A month.
A month, okay. So if when are you guys done?
Sunday.
On this Sunday? Very good. And you took your internal medicine test yet? Or
No.
Friday? Okay. So you do it online or how does that work?
Monday. Yeah, we go to school and then we take it online.
Online over there. Okay. Well, all right. Good luck. Yeah, it's this is your life. I still have to take my really certification in internal medicine boards next year, so it's never ending. Okay, so why don't you help me read the first question and we'll break it down.
55-year-old man is referred for chronic resistant hypertension despite taking lisinopril, chlorothalidone, amlodipine, and metoprolol. He is compliant with medications. He drinks 3 to 4 alcoholic beverages per week. He is also with a 9-point stable who snores but denies hypersomnolence or headaches and is either unaware of apneic episodes. His blood pressure is 160 over 90 consistent with readings. He is obese with a BMI of 35 and a class 1 kidney edema. Creatinine is 1.0, potassium is 3.8, and urinalysis is negative for albumin or cells. His CSH is normal and his serum calcium and PTH is also normal. Which of the following is most correct? His alcohol intake is likely contributing to his resistant hypertension. A high sodium diet is not contributing to his hypertension. Polysomnography would most likely be positive for sleep apnea. Polysomnography is not indicated since he does not have specific symptoms of sleep apnea.
Okay, you don't need to answer the question because we're gonna cover like each of the options. But you guys know the definition of resistant hypertension by the American College of American Heart Association is being above goal despite concurrent use of at least 3 antihypertensive medicine, including a diuretic, and all of the medicines should be maxed out. So the prevalence of resistant hypertension is pretty high because if you're controlling, you're taking 4 or 5 medications, you still fall into this category of resistant hypertension. And the take-home message that I want to emphasize today for you guys is that in clinical practice, it's a lot more common to find pseudo-resistance than actual resistance. And we're going to talk about pseudo-resistance. Your job as a primary care provider is to make sure you cover the ABCs. When you're learning ACLS, they teach you ABCs. Today we're learning hypertension. I want you guys to always cover your basics, your ABCs with every single patient, because if you're just there to titrate medications or to prescribe the medication, you're going to get it wrong in real life, and you're also going to get it wrong on your boards, because for the most part they want us to establish the diagnosis, usually get some sort of like non-pharmacological recommendations, and then you move on to medications. This is different than the course of action that we were discussing the other day with hypertensive emergency. Hypertensive emergency, it's by definition is an emergency. By definition requires that the patient comes into the hospital and that you give them IV parenteral therapy to try to bring them down. And we talk about the goals is very different if you have a hemorrhagic stroke or if you have a ischemic stroke or if you have some sort of like dissecting aortic aneurysm. Those patients, they need to be brought down fairly quickly. Versus hypertension in the community, this is more of a long-term risk. There's really nothing asking you to take aggressive action. And my advice to you guys when you're in clinical practice is try to introduce one agent at a time and try to titrate it as tolerated. I know in clinical practice it doesn't happen that way, but in my practice, what I do is I usually start the patients on something and I bring them back in 2 weeks. Because we all know from pharmacology that it's better to wait until the medication builds up at least 5 half-lives before you end up making a decision, clinical judgment on whether or not you need to adjust medications. So if you take a look at the prevalence of resistant hypertension, it's pretty high. And a lot of the things that's important for you to know for your boards is that prevalence, the patients with resistant hypertension, they're more likely to have secondary hypertension. Remember, we don't call it essential hypertension anymore. We call it either primary hypertension or secondary hypertension. So if your patient has resistant hypertension, that's one of the indications to pursue a secondary hypertension workup. But like we were covering the other day, when we hear hoof sounds, we think about horses, we don't think about zebras. over 90% of the cases of hypertension are primary hypertension. Our job is to identify and to appropriately treat those with primary hypertension. For the rest, I'm going to be covering some of the more commonly tested secondary hypertension causes on your boards. You don't need to know like genetic syndromes that I rarely see in my practice, but I'm going to mention some of them, so you guys are familiar with the differences in how to approach these cases. But what I want you guys to concentrate that you have to think about pseudo-resistance in every single patient. And the pseudo-resistance is either because your patient is taking inadequate medication doses, number one, or the patients are not taking the optimal medications, or they're not taking first line or second line. We're going to do some exercises on which medications you want to try. Or the patients are not taking the medications as prescribed. Remember we talked about last week about how important in clinical practice, when they do, like pharmacists, they do clinical studies, the non-compliance can be as prevalent as 25 or 30%. That's pretty impressive. If you realize, like you ask your patients and they tell you, yes, I'm taking my medications, and they tell you that for whatever reason they don't want to be embarrassed to say no, or they don't want to, they're afraid to tell you. I don't know what the reason is, but in clinical practice, I encourage you guys to always do a medication review. Look at the labels, look at the bottles. If you work in a managed care organization like I do, it's very simple because I just look at the pharmacy electronic health record and I know when they refill it. If they bring the bottles, you can actually count the pills. If you're in a community setting, you can even call the pharmacy and say, hey, when was the last time this guy, or last year, how many times did he refill this medicine? So at least you get a sense of those patients that are non-compliant. And trust me, it's not as straightforward as you would think it is. Like, oh, do you take your medicines? Yeah, I take them. A lot of patients, they don't take them. And, I had an experience when I was a second-year resident. I had an HIV needle accident, and I had to take 4 drugs for a month. And I'm telling you that was a very eye-opening experience for me, because I realized how hard it is to take pills at different, time of the day. And also, I was exposed to a lot of side effects. I had a GI upset, I had diarrhea, I was just not feeling right. So when I prescribe medications to my patients, I always try to find a regimen that it simplifies their life. They have a lot of things in their plates. If you prescribe regimens that involve like 4 times a day regimens, it's probably not going to happen. And that's one of the problems that I have with hydralazine, which is very commonly used, but the reality is that you have to know who you prescribe it to, because a lot of the times patients, they're not going to take it 4 times a day. Imagine if I tell you, take a medication 4 times a day. How many times have you missed the amoxicillin, or how many times you don't finish that amoxicillin that they gave you for whatever reason? So always in hypertension medicine, think about what is it that I can do to make it the easiest for my patients. So, and then you talk about obesity. Obesity is a cause of pseudo-resistance, and that should always be the case for every patient that you see. You need to counsel them about physical activity and weight reduction. So on your boards, they're going to throw you a question, a guy with clear-cut criteria for hypertension. First time you see him in the clinic, no evidence of end organ damage, and they're going to want to trick you, so you answer medications. First thing that you do is you basically advise low sodium, you advise weight reduction, and you identify potential medications that can be associated with secondary hypertension. Do you guys remember some of those medicines that can be associated with hypertension? We talked about some of them last week. You guys remember? Which medications, when you do a medication review, which medications are associated with hypertension? There's something you're going to be prescribing like candy.
Steroids?
Actually, more common is actually NSAIDs. NSAIDs are notoriously associated with secondary hypertension. It inhibits prostaglandins, which are like the natural vasodilator from the efferent arterioles in the kidney. So invariably, patients that are on NSAIDs, they're going to be a little hypertensive. So when you're prescribing NSAIDs, you're going to think about a few things. You're going to think about, does this patient have hypertension and maybe uncontrolled hypertension? Probably not a good idea. Does this person has chronic kidney disease? Probably a bad idea. And does this patient has heart disease, like ischemic heart disease? You don't prescribe that to those patients, because they can go into irreversible renal failure. The renal perfusion is already so compromised that you don't want to give those medications, especially if they have a lot of gastric and GI toxicities. And by the way, the FDA recommends against the use of NSAIDs in patients over the age of 65. I'm letting you guys know that because I'm pretty sure you guys are going to be moonlighting in the urgent care, like I did when I was in training, and you're gonna be relying a lot of your medical decision making on NSAIDs. But I want you guys to put a little bit of judgment on an individual cases. You're gonna ask yourself, okay, this. If not, you can just prescribe it. But NSAIDs is probably the most common one. So on your boards, look for NSAIDs. The next step in the management is stop the NSAIDs, bring the patient back in 2 weeks. That's the next step in the management.
When you say last time that you don't like the
COX-2, yeah, I don't prescribe them because in my field, NSAIDs and for nephrologists, we don't get along. Right, and back in the days, like you guys probably were in elementary school, so there was a lot of noise on some of the COX-2 inhibitors. In fact, they took them all out of the market. The only one is Celebrex. That's the only one that I know is left. But there was big lawsuits from Biox. There was like another one. I can't remember the brand name. And the bottom line is that those medications were associated with an increased cardiovascular mortality and strokes. And this is again is the same question that you need to ask yourself: is this person the right candidate for taking an NSAID? And if it's an old person, no. Heart disease, no. Kidney disease, no. History of bleeding or gastric peptic ulcer disease, no. And if the patient has hypertension, no. So always have that in mind when you're going to prescribe an NSAID. But there are many other medications. Which other medications are associated with hypertension? You guys remember? Just throw me a few. There are many. Which medications can cause hypertension? So they're going to give you another vignette with a young female taking OCPs. So it's the next step in the management is refer back to the OBGYN for an alternative contraception method. If you stop the OCPs, they're going to blame it on you. That baby's yours.
For the estrogen progesterone OCPs, or would it also be for like the?
It's only the estrogen based, yeah. So when you guys were, when I was in med school in the 1990s, hormonal replacement therapy was so huge. Like I remember we got this amazing conference. They brought food, brochures, talking about Premarin and how amazing this drug was the new promising thing against dementia and against osteoporosis and against like sexual life and what you name it, like menopausal symptoms. We all know that now the evidence is overwhelming to the point that towards the end of the 1990s, the FDA actually issued a statement that these studies were terminated because the evidence was very overwhelming towards the increased risk of strokes, heart attacks, and breast cancer on the women that were taking it. So nowadays, you're still going to see some patients taking them. I'm pretty sure that if you see your mom taking it, you're not going to want to have her take these kind of medications. So some doctors still prescribe it, but just have that in mind if you're dealing with hypertension medicine and if you see estrogen-based, not only for hypertension reasons, but we should try to discourage the use of this. In other words, we use hormone therapy these days on a very individualized basis after having a very clearly documented discussion and with a start date and with a stop date. In other words, it's not like in the old days, like you take it and then you take this until you die. We don't do that anymore. So there are other over-the-counter medicines that can be associated with severe hypertension. Patients that are using Afrin, oxymetazoline or Sudafed, like the people with like sinus issues. Those stuff can cause severe hypertension, especially if you have underlying like hypertension. But we also have like the recreational stuff, like people using cocaine, amphetamines, PCP. That stuff can be associated with significant hypertension. So you need to inquire about those things when you're getting your history as an intern. We also have other prescription drugs that are associated. Go ahead.
I was just thinking, aren't there a couple of like natural supplements?
Yes, I think St. John's Wort is one of them. This for depression. I think that stuff can cause a little bit of hypertension and liver failure. And anything that has like ephedra, like the appetite suppressives. Like there was something called fen-phen. Like you probably see patients here in the clinic that they were exposed to fen-phen back in the 90s, early 2000s, and they have valvular heart disease. So, but there's still like supplements out there like for appetite suppression, hydroxycut. They have like all sorts of things, and they keep pulling them and they come up with a different name. So those things can cause it. Same as the prescription equivalents like amphetamines, for whatever reason, if they're prescribing it for ADHD or for narcolepsy or for whatever, energy, the Provigil, all those things can be associated with severe hypertension. We also have other things like, have you guys heard about calcineurin inhibitors? So those medications we use for solid organ rejection prophylaxis, among many other things. We use them for, sometimes in my field, I use them for management of some specific glomerulonephritis. So calcineurin inhibitors are cyclosporin and tacrolimus, Prograf or Gengraf. Those medications both can be associated with hypertension, perhaps cyclosporin more than tacrolimus. In my field, I also use another medication that is associated with hypertension. In fact, you're not supposed to give it if the systolic blood pressure is greater than 165. It's called EPO. I don't know if you guys know what EPO is, but it's one of the erythropoietin stimulating agents. There are several that are FDA approved. And we use it for management of anemia of end-stage renal disease. And I have to check blood pressure every time I'm going to give it to my patients. So that's one thing. So we have other drugs like cancer drugs that are like novel cancer agents that are targeting the VEGF pathway, the vascular growth endothelial factor blockers, inhibitors. Those medications can cause severe hypertension and proteinuria. So there's a lot of things, but for your level of training, I want you guys to concentrate on reviewing the meds, thinking about NSAIDs, OCPs, decongestants, and yeah, I think that's pretty much what they want to make sure that you cover that. And lastly, I want to make emphasis on the poor diet. And I have a slide here that you're going to be like, wow, I can't believe this is the way we eat here in America. So, all right. So going back to your case. So the guy was denying adding any extra salt in the table. How do you assess for dietary sodium intake? What kind of questions do you ask your patients? What kind of do you eat out a lot? And do you eat processed foods? You know, do you buy your food in the middle of the supermarket, like all those freezers with the nasty processed foods? So you need to inquire that way, so you get a sense of where the patient is coming from, because the vast majority of the sodium, the dietary sodium, doesn't come from adding sodium. It comes from eating processed foods, which is very common. Most of our elderly patients, they live on a budget. They have very limited money, and they go and they buy these TV dinners because it's cheaper than actually cooking a whole meal. So always inquire about that in the setting of kidney disease, liver disease, heart disease. Is very important that they even more important that they're on a sodium restricted diet. So this slide actually shows that the average consumption of sodium in the United States is anywhere from 36 to 4,800. Do you guys remember what the American Heart Association recommendation for hypertension? It's actually less than 2,000 milligrams. Less than 2,000 for some patients. We recommend like less than 1,800 milligrams per deciliter. I'm sorry, milligrams in a 24-hour period. Do you guys think there's a way to assess compliance with sodium? Like a patient comes in and he's telling me, you know what, I'm eating a low sodium diet. Is there a test that I can send to assess the sodium? And no, actually there is you can send a 24-hour urine sodium, and you multiply that by the molecular weight of sodium, which is 23, and that converts that into milligrams per deciliter, milligrams per day. Sorry, I've only done it once, and I was very surprised, and my patient was even more surprised. I had a patient with recurrent calcium oxalate stone formation, and one of the key elements of managing these patients is to adhere to a sodium restricted diet. So I sent her for a 24-hour stone metabolic assessment, and one of the reported elements is the sodium. To my surprise and to her surprise, she was ingesting about 7,000 milligrams of sodium, and she thought she was doing a good job. So you guys haven't done this because fortunately we're not sick, but I want to invite you guys to try to, at least for one day, to eat a sodium restricted diet, and you're gonna realize how difficult it is. If you count your labels and if you cook, like trying to see how it is to have heart disease or kidney disease, is quite difficult. So this, I cannot emphasize enough the importance of this issue if you're dealing with hypertension medicine, because a lot of the pseudo resistance comes from this specific issue. We know from clinical trials that just by modifying the way we eat, we can bring down, some studies show like anywhere from 4 to 9 millimeters of mercury reduction in the systolic blood pressure if you adhere to a sodium restricted diet. So that's huge, because that may be the difference between not taking medicines versus taking a medication.
How long would you be on that diet before you see the difference?
I usually tell the patients, I bring them like for a month. So when the patients are eating poorly and then they're obese and they're not doing any physical activity, I invite them to do this kind of stuff, and I bring them back in about a month. That should be enough for your body to excrete all the sodium and to adjust to the new baseline. Okay, so this is a study showing the effect of sodium restriction on systolic blood pressure. You can see there's like a delta 6 millimeter of mercury change, but like I said, there's some studies that I was reviewing that use even more dramatic. So this is the urinary sodium in millimoles. You multiply these by 23, and that's how you get your 24-hour sodium data. Okay, so it comes to the point like why is it that we don't classify obesity and poor diet as a secondary hypertension? If you think about it, we should, right? It's just part of the reason why somebody with the genetic makeup to be hypertensive ends up becoming more hypertensive or declaring himself, and is a modifiable factor. And that's the reason why I make a lot of emphasis, and the boards make a lot of emphasis on this, because it's modifiable. And we all, oftentimes I get a call from the other internal medicine doctors asking me, hey, I have this patient, CKD stage 3 to 4. I'm giving him this, and blood pressure is very high. So if you think about it, the example that I use for my patients is, just think about it as a clogged sink. If you're putting more water and more sodium, the water is going to overflow. And the manifestation of the kidney disease patient with a poor diet, it's severe hypertension. So some doctors, they like to classify kidney disease as a secondary hypertension. I always use that example in perspective for students and residents and interns, because they need to understand that if you have kidney disease, it's fundamental that you educate your patient before you prescribe anything. Educate them about, there's so many nephrons that you have. Those nephrons, they don't have the ability to concentrate and dilute the way they used to. They don't have the ability to excrete sodium the way they used to. So you have to be on a sodium restricted diet. So, and then we have like the other common associated things with secondary hypertension. I already talked to you about the drugs. We have sleep apnea. I have some slides that you're going to find very interesting later. And then we have primary hyperaldo. That's a board favorite. So make sure that you know the triad of constellation of symptoms: severe hypertension, metabolic alkalosis, and hypokalemia. I have some slides here just to show you how to do the workflow for these patients. And then we have renovascular hypertension. On your boards, we have the two types. One is the atherosclerotic renal artery stenosis, which is plaque forming from the, just envision seeing the aorta, and just envision the plaque going into the proximal third of the renal arteries. If they show you an aortic angiogram or picture, and you see the plaque extending from the aorta to the proximal third, you know that you're dealing with atherosclerotic renal artery stenosis. And I want to say two things about atherosclerotic renal artery stenosis. It's an old person's disease, unless you have accelerated atherosclerosis because of whatever reason, one of the familial hypercholesterolemia syndromes, or you have severe nephrotic syndrome. Those patients, remember, they develop severe hyperlipidemia. But for the most part, I'm talking about old people. And the second thing I want to say is that say it again?
Fibromuscular dysplasia?
No, the second one is fibromuscular dysplasia. But the last thing I want to say about atherosclerotic renal artery stenosis is that it's almost never seen as an isolated entity. In other words, these patients, they always had a history of peripheral vascular disease, carotid endarterectomy, status post-CABG, like they're vasculopaths or history of stroke. So just think about like you're going to see patients like this here. So if you have a patient with difficult to control hypertension and like atherosclerosis everywhere, you have to suspect that that's probably what you're dealing with. It doesn't really change the management because nowadays we know that those interventions that we were doing before, the stents, they don't really, for atherosclerotic renal artery stenosis, they don't really change the renal outcome or the morbidity and mortality outcome. Nowadays, we still do them on individual basis on some selected patients that are impossible to control with medications. Because the procedure, studies have been able to demonstrate that stenting those patients, you can still bring their blood pressure down, but it doesn't really change prognosis in terms of morbidity, mortality. And that's where the argument that people that are experts in the field, they feel like we shouldn't be doing them because they don't really help the patients. A very different story is what you're mentioning, the fibromuscular dysplasia. It happens in the mid or the distal third of the renal arteries. Typically, they give you a younger patient, like a female. This is not only seen in females that are born with this, but you can also see that in some patients with a history of vasculitis, some patients with abdominal trauma, or some patients that were exposed to total abdominal, total body or total abdominal radiation therapy for cancer earlier in their lives. So the bottom line for your boards is that if you see that the obstruction is a younger person and the obstruction is more distal, you think about fibromuscular dysplasia. For those patients, they do benefit from angioplasty, and because it actually translates into better blood pressure control and better outcomes. It's different for the other ones because the reality is that the morbidity and the mortality in the other group is so high because these patients already have fairly advanced atherosclerotic burden everywhere else. Okay, so then I have a hypothyroidism. Both hypo or hyper can cause severe hypertension. So part of the workup of secondary hypertension is to get a TSH. And sometimes you need to do a TSH T3, T4 because if you have primary hypothyroidism, it makes sense. But if you have like central hypothyroidism, the TSH is useless. So you need to order like TFTs, full TFTs. Then we have primary hyperparathyroidism. You guys remember what is the typical patient with primary hyperparathyroidism? What's the classic triad of these patients for your boards?
Calcium.
They have high normal or borderline or borderline hypercalcemia. They have hypophosphatemia. Phosphorus is low and the PTH is high. So this is the classic primary hyperparathyroidism. Remember, there's 3 types of hyperparathyroidism. They're all very different in the way they present, the physiopathology behind. Primary is a parathyroid adenoma. Anybody can have it. And sometimes these patients, like if you have a patient with recurrent calcium oxalate kidney stones, they need to rule out primary hyperparathyroidism. Or if you have a patient with osteoporosis, that's actually an indication to just go and, if the patient is younger, just to go and take care of the adenoma, just resect it. So usually ENT is the specialty dealing with these patients, and they usually do a nuclear medicine, a parathyroid scan, just to see where the excess parathyroid hormone is coming from. It lies up, and they go and they resect the parathyroid gland.
Question on the subject of osteoporosis. Can you give a diagnosis of osteoporosis without any kind of like DEXA scan?
There are other tools to assess for osteoporosis, but in clinical practice, the standard of care is a DEXA scan. Yeah, and most managed care organizations, they do very specific guidelines and when to screen or who to screen. If you have a younger person with no other risk factors with osteoporosis, you have to think about primary hyperparathyroidism until proved otherwise. And these patients, like I said, they can present with recurrent kidney stone, calcium oxalate kidney stone. So high PTH, high calcium, and low phosphorus, and hypertension. That's another part of the syndrome. That's how they present. And in lower, the size, I put these last 3 because the incidence is not very common. So coarctation of the aorta maybe on your boards they're gonna want to ask you for somebody with Turner syndrome, and the way you diagnose them is by doing a blood pressure in the arms and in the legs, and there's a significant discrepancy. That's how you suspect it clinically. But usually you diagnose it with either an echocardiogram or a CT of the chest abdomen, because the coarctation can happen anywhere along the thoracic or abdominal aorta. And these patients, they need to have an intervention, and it's treatable. Is it common in real life? I'm yet to see the first one. Is it common on your boards? Yeah, like pheochromocytoma. I've only seen 2 cases in my career, and one of them was my co-fellow when I was at UCLA doing my nephrology fellowship. She started having like classic symptoms like flushing, orthostatic hypotension, palpitations. They thought she was crazy, and she self-diagnosed with pheo, and she had to go through surgery. And I still remember it because it was very painful covering her pager. But I'm glad that she's better, and she did well, and she's my good friend nowadays. And so that's basically pheo. I'm gonna try to cover. I have some slides at the end, towards the end. And then Cushing syndrome is fortunately not very common, but they ask a lot of questions on your boards. So usually you look for the Cushingnoid appearance, the obesity, central obesity, all the features like the moon facies and the buffalo hump and the abdominal stretch marks and striae, and these patients they're easy to diagnose because we do 24-hour urine for cortisol, and that's how you diagnose them. But you can also have secondary Cushing's or from exogenous exposure to steroids. That's actually, I've seen that more commonly than the actual primary Cushing syndrome. And the reason why I see it is because we're so close to Mexico that a lot of our patients with undiagnosed rheumatologic conditions, they end up getting some of these formulations. Like the other day I had a lady who came in with this BS supplement that I'm pretty sure it had NSAIDs and steroids because her face was already like pretty cushy now, and she had pre-diabetes, and she told me she's been using it for 5 years. So you're gonna see that a lot if you end up practicing here in LA, because we're so close to Mexico. But these patients can present with the triad, like obesity, the phenotypic changes, and pre-diabetes and hypertension. So
how round is her face? Could you not realize her being obese?
yeah, it's difficult to distinguish, but that's when you have when you develop these clinical skills, you look for acne, you do a good exam. There's some obesity that are just not normal. Like the obesity from Cushing is very different. These patients, they have muscular atrophy, especially like proximal muscle atrophy, and they complain of weakness. That's a side effect from the steroids. They may have acne, unrecognized diabetes and unrecognized hypertension, and I've seen it. I've seen this. It's not common, but I've seen it in my practice.
I found that it's hard to, phenotypically differentiate them from like PCOS patients. Like
very different. Very difficult.
They're hard. Like when you see them, you initially, is that a Cushing's patient or not?
Right. That one of the things that you do is basically, if your 24-hour urine cortisol is negative. You don't keep looking further. But in polycystic ovarian syndrome patients, they're very easy to diagnose because you just do an ultrasound.
Not to get off track, but speaking about PCOS, a childhood friend of mine, I guess, diagnosed with PCOS, and she's like literally as large as Caroline, and like not
right.
any.
Not everybody's obese. Yeah.
So it doesn't necessarily have to be that way.
No, not necessarily. Some of them, they synthesize these hormones, and some of the Cs are not functioning. How old is your friend?
33.
Yeah, she's young. Yeah,
And it was like 5 years ago.
and it's likely to get better when she goes into menopause. Okay, so going back to our same patient, do you guys think there's a lot of alcohol, or just pretty average for everyone here in this country?
Well, is it actually 3 to 4 beverages a week?
Yeah, that's-
How many ounces?
Oh, I'm sorry.
Question.
Let me call KP dialysis unit. Let's say